Assalamu alaikum wa rahmatullahi wa barakatuh. For the upcoming session, I would like to welcome Dr. Rabi Hanna, or Rabi Hanna, I apologize. Dr. Hanna is a clinical researcher specializing in pediatric hematology oncology, and hematopoietic stem cell transplantation. He's currently the chair of pediatric hematology oncology and BMT department at Cleveland Clinic. He is experienced in both clinical and translational research, which prepares him to initiate and collaborate with other investigators in conducting studies with the goal to improve patient care and outcomes. Dr. Hanna, I'll give you the floor.
Good afternoon, everyone. At the beginning, I would like to thank the organizing committee for inviting me to this really fabulous place. This is my first time here in Saudi Arabia, and I'm so grateful for you. And I also want to thank you for asking me to speak on a disease that it is really so close to my heart. This is my disclosures. As you could see that I do serve in some capacity and with companies either as a consultant or speaker that they may be relevant to my talk today. So at the beginning, what I want to talk about is just very briefly discuss sickle cell disease, because I do really think this disease is so underrated in terms of the critical thinking and how important it is even globally. This is a disease that there is more than 20 million people affected globally, with 100,000 in the United States. But even here in Saudi Arabia, I was surprised to see how high is the incidence, with approximately 4.2% of the population are carrying the sickle cell trait, and quarter of the population are being affected, especially on the east side of the Saudi Arabia, according to the Ministry of Health 2019 data. Despite that this is really a single nucleotide gene mutation, it is fascinating how variable is the phenotype of this disease. We all know that this is due to single mutation on chromosome 11, but what it is leading, it is that the cell, instead of being really normal shape like this, it will become sickle cell in deoxygenated settings, but it goes the effect beyond just the anemia level and the hemolysis. And I like to think about it as rather a systemic disease and vascular disease, that it is leading to mostly occlusion and vascular disease, with the infarct and the manifestation, it's depending on the age, starting with the pain crisis mostly in infancy and childhood, but even stroke, which is the leading cause in children, death from sickle cell. But as they grow, there is way more complication and morbidity that it's limiting their ability to really live normal life. Even in the US, where it is really very comprehensive centers, we see that the average median life of survival, it's ranged between 43 to 48. So despite of all of this improvement of many drugs that has been recently approved, we still didn't have as much improvement in the life expectancy. And the only cure that was available was the bone marrow transplant that was started in 1984, but due to many reasons, from lack of available match sibling to the sometimes challenges finding match unrelated, but even with the availability of haplo, there hasn't been as much buy-in toward BMT. And just last year in December, we had two products that I'm going to go and review with you today in terms of FDA approval, and also in Europe that approved, and a couple of the countries, including Saudi Arabia, approved for gene therapy, which will be the topic of today. But I'm going to start with a patient case that it will highlight how really helpful is this gene therapy. So this is a patient, I saw her more than a year ago, 29-year-old, who had hemoglobin SS as a genotype. She had multiple pain crises, despite she's been very compliant. This patient, she was even in nursing school, but she couldn't finish it, so she got out. She has been on hydroxyurea, veloxetor, and crizanlizumab. She already had multiple pain crises with an average of 6 admissions per year, and she was spending more than 40 days in the hospital. Her hemolysis, she has a hemoglobin of around 7. In addition, she already had 2 joint vascular necrosis, with already left hip was replaced, right hip was replaced, and she has also proteinuria. So really what the cell and gene therapy, and I put this picture of hope. This is unfortunately an artist with sickle cell who has died last year and couldn't get. He put gene therapy and put this picture that it gave him hope. hope for a normal life. And that's really what we hope to achieve with this. It's what I call it equalizer. But let's go in more details what it is gene therapy. Gene therapy, it is a cellular. It is an autologous transplant using modified stem cell. So the way we collect stem cell, and the collection of stem cell is not the topic of today, but it can be challenging practically, and you really need to develop expertise. It's not the same as multiple myeloma or lymphoma. When you collect these cells, you are going to send them to a company. They use genetic tool, which will be the topic of my second talk today, to go into more details about the differences between them. It takes around 4 to 6 months to have the cells ready, and then you are going to admit the patient back to get their chemotherapy with the myeloablation busulfan, and then the infusion of the modified stem cell. And this is the journey of this patient. So we are going to go first with what we call lovo-cel, which is the gene addition using the lentiviral product. It's called lovo-cel or Lyfgenia product. So we usually pre-mobilize. I cannot emphasize enough how important is that period to try to do red blood cell exchange for 2 to 3 months to get the inflammation, that bone marrow environment to be in a little bit better settings. That will truly help you with the mobilization. When you mobilize, you only use plerixafor. Usually it is done in inpatient for 2 days, and the third day as a stem cell backup. Most of the patients need 2 cycles, occasionally 1. Many patients, they require sometimes up to 4 cycles. Then you send the cells for ex vivo gene addition using an adult-like hemoglobin vector. And then when the cells are ready, they will be admitted. On this study that was published and presented at ASH last year by Dr. Julie Cantor, the inclusion are listed here on the blue box in the bottom. Age was 12 to 50 with at least 2 pain crises per year for 2 years. That's the genotype having hemoglobin SS or S beta plus or S beta 0, no SC. And the patient has demonstrated pain crisis despite being on hydroxyurea, no matched sibling that is available, and they have a good organ function. And then after we infuse the cells, we will watch them during the myeloablation period until they recover. And this was the data that was presented for this patient with the efficacy cohort of 47. So 59 were enrolled, 57 is the analysis for them. And the median time in terms of this patient for follow-up was approximately 3 years. So this is really our longest terms of follow-up for this patient. The longest patient had a follow-up of 61 months, so it's enough period. What I want to highlight quickly in terms of bring to your attention, it was the number of pain crises were 3.5 per year. The number of severe was around 3, and the transfusion was 3. Their usually median hemoglobin was 8.7, so this were the demographic. And in terms of the efficacy, you will see that the patient median, they needed 2 cycles for collection, between 1 to 4 the range. Their number of total cell CD34 was around 6.5 million per kilogram. Time to engraft, their neutrophil was 20 days. Time to platelet engraftment was 35 days, and the hospital duration was around 36. So this is different from your usual autologous transplant. When you are going to open this, you need to think about this for your hospital utilization. And what I feel this was very important to, and many patients, they really tell you how this level of hemoglobin helps them to improve their patient-reported outcome. The data does show, I'm not showing it, that improved patient-reported outcome from fatigue and many others. It does not have multivariate analysis to show if it correlates with the level of hemoglobin, but you could see most of the patients were able to achieve normal level of hemoglobin, and their hemolysis markers in terms of LDH reticulocytes were all decreasing. So this is really not only helping to decrease the pain crisis, so 86% that they achieved what we called it pain-free, no pain, and 94% were no severe pain crisis. So when you review the couple of gene therapy products, be careful in terms of what they are looking at in terms of a primary endpoint. There is a difference between the 2 products sometimes in the way it's reported. Is it severe, which means that it's ED admission or hospitalization or any pain crisis? So that can explains sometimes the difference between the two numbers that you are going to see. So this is a swim plot diagram. So each patient, it is a raw. You will see on the left side, the gray, it is the pre-transplant. The red dots are the number of pain crises that they had. And then after that, you will see there is a washout period, that it is that blue box. And then after it, and it's really exciting to see the red dots there on the right side being so little. So this is really giving the patient much more time to enjoy without pain crisis, with, again, great follow-up in terms of compared with many others. So this is any pain crisis that was on 88%. That's still, I would say, it's considerably great for this patient. In terms of safety, this is important because this is a group. The lentiviral product, this was really over multiple variation of study. There was the one group A and B and C, and there was 2 patients. One developed AML and one actually developed, persistent anemia, and the other one was MDS. And that's why I highlighted here in red. There was a very good review in New England Journal about this case, and that it showed that this was not, they didn't show any evidence that this was related to the vector itself. But I am going to highlight in my second talk some of the concerns about the gene addition, especially in the disease called adrenoleukodystrophy, that it is just last week was published a 6-case series of hematological malignancy in that patient using gene addition data. But the rest of the toxicity that you will see, it is similar to what you would expect with a busulfan myeloablation regimen. With that, let's now switch gears and talk about the gene editing. This is really what in the field is more exciting. As you know, this is using the CRISPR and Cas9 technology. It is more precise. It does not add any additional gene, so that hypothetically should lead to less concern about any hematological malignancy. So this is a study from a company, Vertex, that was the essential study that led to an approval. It used different concept. It uses that biological observation that many patients with sickle cell disease don't have severe phenotype. Why? Because they have elevation in their fetal hemoglobin. And through the last few decades, we know that that production of fetal hemoglobin is really controlled by the BCL11. So what does this gene editing do? It goes and turns off that controller. When it turns off that BCL11, it will lead to increased production of fetal hemoglobin. It's basically putting you back into that 6-month age that you usually don't have as much manifestation. So this is the mechanism of it. This is the journey of the patient. It's similar. Screening, pre-mobilization with the red blood cell exchange. The stage 2, it's the mobilization. It is, again, only with the plerixafor. It's similar inclusion criteria. The age here was only up to 35, but then it goes to the ex vivo. Little bit here, it takes longer to have the stem cell being modified because the gene editing, they use electroperforation, and the yield doesn't seem as good as it is usually with the lentiviral. And then the admission, and then the recovery. So what are the outcomes in this patient? This is the demographic of patient. It just shows that the initial set and then the primary efficacy set, that was a full set, was 46 patients that we will report the outcome in it. The time to neutrophil engraftment here is a little bit longer. We're not comparing it. It's not fair to compare apple to oranges. It's different product, but here in the neutrophil, it is 27 days. In terms of the duration of neutropenia, what I want to highlight is only 17 days. Patients don't get neutropenic here using the busulfan until they are around day 5 to 7 after the infusions. That's why their neutropenia period is less compared to what you would expect of engraftment around day 27. Time to platelet engraftment was 35 days. And the last day in terms of red blood cell exchange is day 19, and to the hospital discharge was around day 31. Similar graph here with The left indicating the pre-transplant, the right, again here it is represented in a blue diamond, and you could see there is much less dots on the right side for each patient. So this is really exciting because it shows that 92.3% of the patients were able to achieve no pain for a 12-month period after the washout. So this is really, again, another exciting. There was only one death in the study due to a COVID patient that had, but there was no disease, no transplant-related mortality that occurred. I'm showing here the adolescent cohort for the pediatric transplanter in the group, and it shows that it is similar efficacy to the primary adult cohort, so it is assuring to have a similar outcome. And there was an updated efficacy cohort data from the patient presented at EHA in June of this year in Madrid, and it shows that with a longer follow-up, many of the patients were able to actually go for a 12-month, and then now the efficacy for the 12-month is now 97%. You're going to hear probably more updated data later in this session. And from a transplant standpoint, we want to see biological response to, not only pain or other mechanism. It is assuring to see that the fetal hemoglobin percentage here, it is for patient gets quickly above 40% and it remains. But what it is also important, it is pancellular. It is all the cells are expressing a high level of fetal hemoglobin. It's not only a clonal. That's really important in trying to protect the patient from manifestation of the disease. We also see that the total level of hemoglobin, it is above 12, and the percentage of the mean corpuscular volume of fetal hemoglobin, it is around above 6, which is, again, 40% to 50% of that. And the closest thing that we can get to a chimerism test, it is really this test that we could see how much of the, this is the pancellularity that I told you it is above fetal hemoglobin. And when we look similar to a chimerism, we see that it is also above 99% of the patient that they will be able to achieve durable marrow and peripheral marrow of the vector from the excess cell. Their hemolysis markers, you could see that they are all normalized in terms of LDH, the haptoglobin, the indirect bilirubin. And final few minutes of the talk today, I want to show you some of the ongoing clinical trial. This is not approved. This is from a different product called Reni cells from a company called Editas. It uses Cas12, but it targets the hemoglobin G1 and G2, which is different from the BCLA11. Those are the director promoter of the that it happens in the hereditary persistent fetal hemoglobin. So it's really mimic more in what happened in nature. It's similar inclusion criteria, similar patient journey almost. And this is the data that we presented at EHA in June, and we're going to present updated data at ASH. But from the data that was presented in EHA, from an 18 patient, it is the patient were mostly hemoglobin SS, and a few that they were S-beta 0. In terms of engraftment of their patient, it was time to neutrophil engraftment was 23, and time to platelet engraftment was 24 days. This is the same plot. Now each patient here on the right, it is on the left, it is in gray prior to the transplant, in orange after, and so far for this patient, all of them has been pain-free, but it has a little bit shorter follow-up compared to the previous study, so we'll have to wait and see what it is, but so far the data is very consistent with the previous two products. Similar increased level of total hemoglobin. The fetal hemoglobin here is represented in orange, and you could see that the patient by month number 3 to 4, they achieve 40%, and they maintain that. This is the other markers of persistent of fetal hemoglobin, and the side effect so far is consistent with what you would expect with the busulfan myeloablation regimen. There has been no severe TAA related to the study, and there has not been any hematological. Few of the other clinical trials, you are going to see some data at ASH from the BEAM study that it used more advanced technology of gene editing called base editing that I will again speak at the second talk about it. But what we are all looking at, it is the final or the follow-up study from that company, which is called the ESCAPE. The ESCAPE would aim to use reduced intensity and non-chemotherapy regimen, which will be really very helpful for this patient because concern is huge among this patient population about fertility and also increased risk of malignancy. And with that, I want to bring you to my patient. So these were her blood smears before doing transplant. You could see a lot of sickle cell, you could see the anemia, and what it is so exciting to see now, really the blood smear. Sometimes seeing is believing. And really when you show her smear, and this patient who is now back, and her nursing school, she has been now more than a year after gene therapy, no pain crisis, no even she was used to have chronic pain medication for her hip. It's better, and it is really, many of these patients, they feel that they are having their life back. So this is my take-home message, that this could provide functional, I emphasize to the patient that this is really functional cure. I will be careful to use that term. And the advantage when I compare that with BMT, that this is autologous, so everyone can be their donor, no rejection, no risk for GVHT, and no need for immune suppression. But there is many challenges, including the cost, the risk for chemotherapy-related infertility, and long-term side effect. And with that, I'm going to turn it to my next speaker.